Hello, class. Welcome to the lecture on the lower leg, ankle, and the foot. We'll start off here with the lower leg and ankle. So moving more distally from our knee joint, remember that our knee joint is mainly comprised between the articulation of our femur and our proximal tibia. As we move down the tibial shaft, we'll get to the place where we designate to be our ankle bones, more specifically our medial and lateral malleolus, is made up of the distal aspect of our medial tibia and our distal aspect of our fibula. If you all remember the load distribution from our knee all the way down to the ankle, you know that the tibia is the bone located on the medial aspect of our leg, and it bears most of our weight. Our fibular bone is located on the lateral aspect of our lower leg, and the specific bony landmarks that make up the distal aspects of our tibia and our fibula makes up our medial and our lateral malleolus of our ankle. They both articulate with the talus bone, which is part of our rear foot. This is the only site where the tibia and the fibula actually articulate with. So just to recap, again, we have our tibia and fibula. They both articulate on some aspect of the talus bone, and our talus bone will then articulate with the calcaneus bone on the posterior aspect, and our navicular and cuboid bones more so on the anterior aspects of our foot. Two joints make up the ankle in total. We have our talocrural joint. Again, this would be the articulation between the talus, the tibia, and the fibula. We would consider this as our ankle joint proper. The ankle movements that are realized about the talocrural joint will be our plantar flexion and our dorsiflexion actions, as you see here in the image to your right. Next, we have our talocalcaneal joint. This is where we see our inversion and eversion action occurring. And this joint site is the articulation between the calcaneus and the talus. So when we speak about the ankle joint, again, two main joints. One joint is responsible for plantar flexion and dorsiflexion. Plantar flexion is when your foot points down. Dorsiflexion is when your foot points up. And our talocalcaneal joint site, where inversion and eversion is realized, this is the articulation between the calcaneus and the talus. So within our ankle joint, we have a lot of ligament support, starting on the medial side. Notice on the medial ankle, these will be the ligaments that are attaching the tibia to various bones in our rear foot area. So on the medial aspect, we have our posterior and anterior talotibial ligaments. We have our calcaneal tibial ligament. We have our tibio-navicular ligament. All of these ligaments are comprised into one ligament region, and this will be referred to as the deltoid ligaments. So each one of these ligaments will be categorized as a deltoid ligament. Just know that our deltoid ligaments are located on the medial aspect of our ankle. On the lateral aspect here, we have our anterior and posterior talofibular ligaments, as well as our calcaneofibular ligaments. Because we are dealing with the lateral aspect of our ankle, these will be the ligaments that are attaching our fibula bone with rear foot bony attachment sites. So the main injury that I'm sure a lot of you guys have either seen or experienced is our simple lateral ankle sprain. And the main ligament that will be affected will be this anterior talofibular ligament. And this will be the ligament attaching our fibula with the talus bone on the anterior side. You also may see some damage here in the calcaneofibular ligament as well. Just know that the ligaments that are mostly compromised in the lateral ankle sprain will be the ligaments found on the anterior side. Obviously, depending on the nature and severity of the ankle sprain, it may go from just a simple stretch of these ligaments all the way to complete rupture of lateral ankle ligament compartment, which may also come with minute fractures or dislocations and that sort of thing. Just to recap, just know that the ligaments on the medial aspect of an ankle will be deltoid ligaments. The names are as followed, and on the lateral aspect, it will be the ligaments that are attaching the fibular bone to rear foot bony attachment surface. More severe type of ankle sprain, if we're comparing our traditional lateral ankle sprain to a high ankle sprain, is the tearing of the tibiofibular ligaments. Now, I don't think I touched on this, but our tibia and our fibula are essentially held together by the proximal and distal tibiofibular ligaments. And it's also brought together by this interosseous membrane. So with a high ankle sprain, we're dealing with the mechanism that ruptures the distal tibiofibular ligament, as well as the interosseous membrane that holds these two bones together. Again, comparing to the lateral ankle sprain, this is considered more severe, and it may take at least 6 weeks to come back, just depending on the severity of the high ankle sprain. Again, the anterior tibiofibular ligament is the one that's most commonly affected, and this will be the anterior tibiofibular ligament located on the distal aspect of the tibia and fibular bones. So right around here. Usually the mechanism involves excessive dorsiflexion with eversion and external rotation. Also, if you land on somebody's foot and your foot rolls in a more anterior posterior direction, that may also cause the tibiofibular ligaments to stretch and or strain. The Ottawa ankle rules are a rule of thumb that a lot of practitioners use to analyze whether a particular ankle injury needs to be x-rayed. Those are outlined here in front of you, not really relative to any testable materials. Just know that practitioners would abide by these guidelines to see if an ankle x-ray is necessary or if a foot x-ray is necessary. Moving on to the movements of our ankle. Again, we have dorsiflexion, that is the movement of the top of the ankle or foot towards the anterior tibia. We have plantar flexion or extension. This is the movement of our ankle or foot away from the next. We have our ankle eversion and inversion action. Eversion is turning our ankle or foot outward. It can also be described as foot abduction or moving the foot away from the midline. And whenever you engage in this eversion action, your body weight will be on the medial aspect of your foot. Inversion action would just be the opposite of that, essentially, in which the weight would be on the lateral aspect of your foot. And this would be the turning inward of your ankle or foot. Another note here, you may also see the word subtalar joint. Subtalar and talocalcaneal joint essentially just means the same thing. Just depending on the references that you use, just know that the articulation between the talus bone and the calcaneal bone is where we have our ankle inversion and eversion actions. Lastly, we have our ankle or foot pronation and supination. Now for pronation, this would be the combination of ankle dorsiflexion, subtalar or talocalcaneal eversion, and forefoot abduction. Supination will be the combination of ankle plantar flexion, subtalar inversion, and forefoot adduction. Just know for foot pronation and supination, this is the combination of ankle and foot movements. It's the only movements that we see about the ankle joint that also requires some action of the mid and forefoot areas. Also, I highly suggest for you all to watch this video that I did a couple months back as far as foot supination and pronation actions during the gait cycle. As we move forward into the foot lecture, this will kind of make sense when I present some other mechanisms that we see about the foot. Now, for the ankle and foot muscles, just like the hip, these muscles can be grouped according to location and functions. And just to make it simple and easy, I also added the relative actions about the ankle pertaining to each individual compartment. So the muscles that I found on the anterior compartment will mainly be our ankle dorsiflexors. Muscles that I found on the posterior aspect will be our foot plantar flexors. Our lateral compartment will include our ankle and foot everters, and the medial compartment will include our ankle and foot inverters. Of course, this is organized in a way for you all to group the muscles that we're about to go over into respective groups, but as always, several ankle and foot muscles produce more than one movement. So just be aware of that as we move along to the muscles of our lower leg. Starting off on the superficial posterior aspect, we have our gastrocnemius, we have our soleus, and we have our plantaris. These muscles will be the main engine for our ankle plantar flexion action. Both heads of our gastrocnemius muscles do cross the knee joint specifically, so contraction of these muscles will also cause you to flex your knee, and they connect to the calcaneal tuberosity of the rear foot via this long, strong tendon known as our Achilles tendon. So whenever our knee is fully extended and we engage in plantar flexion, our main movers will be our gastrocnemius muscles. Now, another major ankle plantar flexor will be our soleus. Notice that our soleus does not cross the knee joint. However, the soleus does share a common insertion site, which is the calcaneal tuberosity via the Achilles tendon. So this muscle is usually activated when your knee is in a flex position. Individuals that are familiar with the seated calf raises, in that exercise, you're mainly activating, or you're activating your soleus muscle more so than your gastrocnemius muscle in that plantar flexion action. A lot of you all may be familiar with the debilitating injury that is the rupture of the Achilles tendon. And again, of course, this makes sense only because our major plantar flexion muscles' sole attachment to our foot is that Achilles tendon. So if that ruptures, our ability to push off our leg is completely compromised. It's for that reason why you won't see me playing basketball at the age of 40. And it probably should be sooner, but I digress. Achilles tendon is very important to our ability to push off the ground, walk, run, ambulate, etc. We also have our plantaris. Again, this is not a major mover muscle. It does help with knee flexion and plantar flexion, but compared to the gastrocs and the soleus, its contribution is relatively minuscule. Moving more deep in the posterior compartment, we have our tibialis posterior, our flexum digitorum longus, and our flexor hallucis longus. These muscles are also responsible for the ankle plantar flexion action. And you'll also begin to notice trends as far as the nomenclature or the naming of these muscles. For example, the tibialis posterior is a muscle that is located on the posterior aspect of the tibia. And because the tibia is located on the medial aspect of your lower leg, once this muscle contracts, it will also cause your foot to invert, all right? So individuals who engages in a lot of jogging, sprinting, etc., this muscle, along with the tibialis anterior, is the main culprit for your shin splints. So if this muscle is tight in any way, it's going to essentially pull on the tibia bone, and you may have some soreness along those areas of your tibia. Our flexor digitorum muscle is analogous to the digitorum longus muscles that we see in the upper extremity, in which it will act to flex digits 2 through 5 of our foot, along with the tibialis posterior and anterior. It does contribute to that inversion action. Now, for our flexor hallucis longus, whenever you see the word hallucis, this means that this is a muscle that is primarily acting on our big toe. Remember, on our upper extremity, the word pollicis is used to categorize muscles that act on our thumb. Same idea here. The difference is the name hallucis is used to describe muscles that act on the big toe. So by the name in the compartment, you know that it contributes to plantar flexion of that first digit, our big toe. And because our big toe is located on the medial aspect of our foot, it also contributes to that inversion action. The muscles that are located on the anterior compartment will be our main ankle dorsiflexors. Here we have our tibialis anterior. We have our extensor digitorum longus, our extensor hallucis longus, and our peroneus tertius. Now, whenever you see the word peroneus, this is an analogous term to fibularis. So depending on the references that you use, you may see the word fibularis tertius instead of peroneus tertius. Fibularis and peroneus mean the same thing. So when you see the word peroneus, you know that this is a muscle that is sitting on top and has attachment sites to the fibula bone. So again, depending on the nomenclature, you pretty much already know where these muscles originate for the most part. You know which digits they act on. And with the compartment, you obviously know that these are the muscles mainly responsible for ankle dorsiflexion. The lateral compartment muscles will be our peroneus or our fibularis longus and brevis. For the eversion action, you can also put in the peroneus tertius as well, only because it's located on the anterior lateral aspect. But as far as the ankle eversion, you can also throw that muscle in there. The lateral compartment muscle group is mainly responsible for that plantar flexion and eversion action. More specifically to the ankle, you notice that is the same pattern of movement that we see for that pronation action, that plantar flexion and that ankle or foot eversion. And it'll be these guys right here. While I'm on this image, I also noticed that we have our retinaculum, same sort of structures that we see about our wrist, and also the same idea. So all of our leg muscles, in order to act on a foot, would travel underneath its respective retinaculum. So on the anterior side, you notice that we have our superior and our inferior extensor retinaculum. On the lateral side, we have our superior and inferior peroneal or fibular retinaculum. And it's actually that superior extensor retinaculum that we may have some pathology very similar to that of the flexor retinaculum of the wrist when we have particular nerves that pass underneath it. And if it's compressed, it may cause some neuropathy type symptoms. And here's a table to organize all the muscles in their respective ankle action. Also gave you this list to organize the muscle compartments in a different way. Notice that we don't have a medial lower leg muscle compartment, and this will mainly be responsible for our ankle inversion action. Notice that these are our tibialis muscles. Because our tibia is located on the medial aspect of our lower leg, contraction of those muscles will cause our foot to move inward. Also, when referring to this slide, pay attention to the muscles that are bolded. Those are the main movers in respect to each of the ankle movements. The non-bolded muscles are just muscles that essentially act as agonists, yes, but also kind of more synergistically as well. All right, moving on to specific mechanisms of the foot. Starting off here with the overall function of the foot. The foot's main job is to support body weight and posture. It obviously contributes to our ability to balance and have some sort of foundation. If we have any abnormalities about our core and hip region, the foot may also compensate for that misalignment or that abnormality realized in those regions. And it also plays a critical part in transferring ground reaction forces and absorbing those ground reaction forces whenever we run, jump, walk, ambulate, etc. So the bones of the foot, we kind of covered the rear aspect already with the calcaneus and the talus. These bones, along with the distal aspect of our fibula and our tibia, will make up the rear foot area. As we move more distal down our foot, we will reach our midfoot area, and this is made up of 5 bones. This will essentially be our 5 tarsal bones. On our big toe side, we have our navicular. On our pinky toe side here, we have the cuboid. We also have our 3 cuneiform bones, just distal to the navicular bone. After these tarsal bones, we'll move into our forefoot area, where we have our 5 metatarsal bones, and we have our 14 phalanges. Very similar to what we see in the thumb, digits 2 through 5 will have 3 phalanges. On our big toe, you only see we have 2 phalange bones. I really like this view up here, only because you can kind of see really how the tibia and our fibula articulate with the talus. And as you move down the foot, you also have a sort of appreciation for how large and how irregular the calcaneus bone is. The lateral aspect of our rear foot is also essentially made up of the calcaneus, right? So sesamoid bones are not only located in our thumb and our patella, it's also located in the ball of our foot, right beneath the big toe area. These sesamoid bones play a pivotal role in increasing the mechanical advantage of our ability to push off the ground. Individuals who are also well-versed in running, more specifically sprinting, you'll hear a lot of sprinters saying that, you know, along with their running form, they also use their feet to grab the ground and push off as well, just to add a little boost to their running mechanics. Interestingly enough, going back to the mechanical advantage aspect, while we push off the ground, these bones will play a pivotal role in activating what we call the windlass mechanism, which we'll touch on here in a bit. We have our gliding joints. These tarsal joints allow for the tarsal bones to glide amongst each other during foot movements, more specifically in foot inversion and eversion. Our metatarsal phalangeal joints, main actions realized here will be our flexion and extension action along with the abduction, adduction action. And for our interphalangeal joint, the only action realized is about the sagittal plane in which flexion and extension will occur. The chart to your right illustrates the specific type of joint that we see amongst each of the foot regions. For the ligaments of the foot, our intertarsal ligaments will connect our mid and our hind foot tarsals. Our tarsometatarsal ligament connects the metatarsal heads to the tarsal bones. The intermetatarsal ligaments will bring the metatarsal heads together. The metatarsophalangeal ligaments will bring the proximal phalanges to the metatarsals, and our interphalangeal ligaments will connect the various phalange bones together. Just know that these ligaments exist. I'm not going to test you guys on these. We have 3 arches of the foot, and the main function of the arches is to create space and transfer the ground reaction forces that are realized about the foot region. I cannot stress enough the importance of these arches and how they allow our feet to receive load. 2 of the 3 arches run longitudinally. So we have our medial and our lateral longitudinal arch. These arches run from the calcaneus to the distal metatarsal heads. And we have our transverse arch, which runs across the proximal metatarsal heads. And we have our transverse arches. And we see these arches running on the proximal and the distal metatarsal heads. Now going back to the medial longitudinal arch, again, this arch is the most common arch that is seen in pathology that we see up the kinetic chain. I spoke ad nauseum essentially in the hip and the knee lecture, specifically pertaining to movement patterns that may cause arches in the foot to collapse. The main arch that will collapse because of these abnormalities seen in the core and the hip region will mainly implicate our medial longitudinal arch. And this arch is incredibly important because this is one of the main arches that are used to dissipate our forces. We notice here to the image on your left, we have 2 different mechanisms that illustrate the medial longitudinal arch's contribution to our ability to walk and dissipate forces. These mechanisms are the windlass and the arch spring. So for the windlass mechanism, and you can actually do this on yourself, whenever you dorsiflex the metatarsophalangeal joint of your first digit, so just dorsiflexing your big toe, what you should see is the formation of your medial longitudinal arch. And within that arch, you should see the contraction and subsequent elevation of the medial longitudinal arch. And whenever a big toe is dorsiflexed, that is the position where our foot is essentially pushing off of the ground. So while this is happening, we also have some biomechanical spring properties that's also within those longitudinal ligaments. Whenever we weight bear, the arches become elongated. And just like a rubber band, the elongation of these arches holds elastic energy. So whenever we begin to engage in our push off point, there's this recoiling effect. And along with the active windlass mechanism of increasing that arch, these 2 things in combination essentially allows us to utilize our plantar flexors more advantageously. Wink, wink, the sesamoid bones located in the ball of the foot also play a particular role in this. It increases the mechanical advantage of our plantar flexors. And this is important because we use our plantar flexors to propel us forward whenever we ambulate. So whenever you see an individual that has collapsed arches, our pes planus flat foot mechanism, it's not really so much the ability to dissipate the forces necessarily, it's a pushing off mechanism that is most compromised. And repeatedly pushing off in a foot that is not able to advantageously push off will cause problems up the kinetic chain. And it can manifest into something as small as shin splints, into some other mechanisms around the hip and the core region. Either way, very important mechanism for our ability to propel ourselves forward, our windlass and our arch mechanism. The arches that I explained in the previous slide is essentially made from the superficial plantar fascia. And this is the overarching broad structure extending from the medial calcaneal tuberosity to the proximal phalanges of the toes. So when I speak of the specific structure that is elongating and recoiling, that structure will be our plantar fascia. It's incredibly critical in stabilizing the medial longitudinal arch and propelling the body forward during the latter parts of the stance phase. A common pathology associated with the plantar fascia is plantar fasciitis. This is usually a painful condition that manifests around the heel area, and it's essentially just inflammation of that plantar fascia due to small micro tears or other abnormalities in the plantar aspect of your foot. Individuals who experience this can present with almost unbearable amounts of pain. And again, if you have any issue with the plantar fascia, your ability to move around is automatically compromised. And again, the area of pain with plantar fasciitis will usually be around this area close to insertion point to the calcaneus. Movements of the specific joint regions of the foot, we see flexion and extension movements in all of the joint regions of the foot. The only location where abduction and adduction is occurring is only at the metatarsophalangeal joints. I put this information up for mainly supplementary purposes. I'm not going to test you guys on the intrinsic muscles of the foot. But however, just for practice, just kind of go over the names and just kind of guess to see, which muscle acts on which specific joint and what they actually do. A lot of the nomenclature that you see here will explain what these muscles do. But just to give you a brief overview, we have a lot of muscles on the foot region, and they are separated into 4 layers. So on our superficial layer, we'll obviously have our plantar fascia. And as we begin to remove each of these layers, the various muscles will begin to come about. Again, I'm not going to test you guys on any of the intrinsic muscles of the foot. Just know that they exist. Individuals that's going to graduate school, professional school, take the opportunity now to kind of get familiar with these because this will definitely come up again. Ending off the neurovascular properties of our lower leg, we stopped off with the popliteal artery located on the posterior aspect of the knee. And we also have these genicular branches which supply the various aspects of the lateral and anterior knee. So from the popliteal artery, there are a couple of bifurcation points. First off, you notice that the bifurcation point on the tibial side will give off a posterior and anterior tibial artery branch. This is important because all of the muscles that are located on the posterior compartment will be supplied by the posterior tibial artery. The muscles that are located on the anterior compartment will mainly be supplied by the anterior tibial artery. As we move down here, the posterior tibial artery will further bifurcate into the peroneal or fibular artery. And because this artery runs on the lateral aspect of our lower leg, this will mainly supply the lateral compartment. Now for the nerves, remember that on the posterior side, we have this huge sciatic nerve. The sciatic nerve is essentially the combination of the common fibular or common peroneal nerve and the tibial nerve. Eventually, there will be a bifurcation point that occurs usually right above the knee joint. However, the specific bifurcation point may vary amongst individuals, but it's usually around the proximal knee joint, maybe a little higher on that posterior side. And as we move down, you notice that we have our tibial nerve and our common fibular nerve. For the muscles that are on the posterior compartment, the main nerve that is supplying those muscles will be the tibial nerve. Earlier on in the lecture, I kind of hinted at a syndrome that is similar to the carpal tunnel syndrome that we see about the wrist. This tibial nerve may also be impinged on the medial aspect of our ankle. That nerve runs next to the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus in the place called the tarsal tunnel. So within that area, even though this is an anterior aspect, on the posterior side, posterior medial aspect, they run right around and underneath that medial malleolus area. And that tibial nerve may be compressed so much so that individuals may develop tarsal tunnel syndrome. And just like